All right, this module is going to look at race, illness, and medicine. So we have mentioned ad nauseum that race is a cultural construct that has biological impacts. One of the biggest impacts of race is on health and longevity. In the United States, there are tremendous inequities between European American and minority health status, Hispanic and African being the most studied. So we have what is known as the infamous Tuskegee study. So the Tuskegee study was conducted between 1932 and 1972 by the U.S. Public Health Service, and its aim was to document the natural progression of untreated syphilis. Now, tertiary and late-stage syphilis typically appears after 12 to 20 years of infection. It's extremely debilitating disease that results in the formation of gumas and severe mental instability. Gumas being soft tumor-like balls of inflammation. If left untreated, it will often result in death. Now, the study sample consisted of up to 600 impoverished African American men. As part of the study, they were given free medical care, meals, and free burial insurance. However, they were uninformed of their infection status, nor were they provided treatment for the disease, even though by 1940 penicillin was readily available, and as a result, numerous of the men died from a treatable disease. So the impact of race on this study is the study was designed and based on the assumption that different races had differential responses to disease. African Americans were believed to be more susceptible to the physical effects of syphilis than European Americans. So the study sample was composed then of individuals from low socioeconomic status. This status, no doubt, was in part the result of racial divisions of wealth and discrimination in the workforce, as well as the lower economic status made the population more vulnerable to exploitation, especially with the incentive of free healthcare. So the overall impact of the study is that in the 1960s, the study's practices came to light and in many instances was likened to Nazi experimentation. This drove the establishment of internal review boards, so the IRBs, and an ethical review of medical practices, including the addition of informed consent and mandatory diagnosis reporting. So we have some generalizations that are made in medical literature and popular discourse in how race affects health and disease. So often one will encounter statistics indicating the association and/or susceptibility to diseases of certain groups. African Americans statistically have higher incidences of cardiovascular diseases, such as hypertension, high blood pressure, heart attack, and stroke. Hispanics statistically have increased frequencies of obesity. So these statistical findings are often reduced to being caused by underlying biological differences attributed to racial differences. So this brings us to a study on racial inequities in health between the United States and Canada. So in 2009, this comparative study was designed to ascertain differences in racial health inequities between the United States and Canada. Overall, the study highlighted some interesting results. Among native-born individuals in the United States, there was far greater health inequities between non-white samples and white samples, while there were very few and/or reduced health inequities between non-white and white samples in Canada. Comparing the two populations directly, it appeared that both Canadian white and non-white samples had better self-reported health and reduced impacts of chronic disease than their American counterparts. So some of the significant conclusions of this study include that chronic disease and health inequities typically associated with particular racial groups, such as hypertension with African Americans, is not a product of inherent biological race differences. It is instead a product of the cultural environment. Canada has less pronounced history of racial division, as well as many modern social programs to ensure access to healthcare and treatment regardless of economic status. In the United States, racial differences in income due to structural discrimination prevent and/or restrict access to healthcare and treatment, which increases the likelihood of these chronic diseases.